I'm really pleased and very honored to serve as the moderator for the first panel today, talking about the broad issues of healthcare and healthcare policy. Today, we're going to focus on the impact of Medicaid expansion and upstream solutions from that implementation perspective. And our panelists are really set to engage in a very thoughtful discussion about what is happening on the ground and across the region and from the state perspective. We're going to talk about successes, challenges, and of course the opportunities that lie ahead, and what we can do as we look ahead at the other issues that are on the table in terms of workforce issues and the Healthy Opportunities Pilot. Before we dive into the panel, I do need to first start with a vital acknowledgement, and that is I need to recognize all of our elected officials who are here today joining us. And thank you for the successful bipartisan effort that it took and the very hard work to pass Medicaid expansion and get us to this moment here today. What an incredible moment for our state because of your efforts, and it's wonderful, so thank you so much. And what it meant is that on December the 1st of 2023, North Carolina officially implemented Medicaid expansion. Lots went into this work behind the scenes. We're going to hear about some of that too, but that was a really important day. And since that time, we're about 3 months into implementation at this point. As we heard from some of our opening speakers, we're here to learn, we're here to talk about what's happening, what comes next, and what do we need to do both in the region and both locally in order to make this a great success. What I can tell you is that so far we're off to a very strong start. As of March 5th, the North Carolina Department of Health and Human Services shows that we have 385,244 people enrolled in Medicaid expansion in the first 3 months. Many of our neighbors here in the mountains who are now newly eligible for Medicaid under the expanded category. So this is really good news. We also know that estimates showed that we had up to about 600,000 folks in our state and across our state who were eligible for Medicaid expansion based on their incomes. And so we've reached a lot of folks and we have a lot more people to reach, and that's part of what we'll be talking about here today. So progress has been made, and we are learning and figuring out how to make more progress and do more each and every day. Now, we have with us this morning an impressive panel of experts. They represent a very broad array of stakeholders and policy issues and decisions that are related to Medicaid expansion and implementation. I will start by just doing a brief, having them go down the panel to introduce themselves, the organization that they represent, and any initial remarks, and then we'll dive right into the questions. So I'll start right here to my left with Casey.
Thank you, Jackie. Good morning, everyone. My name is Casey Cooper, and I'm the CEO of the Cherokee Indian Hospital. And I am here on behalf of the Cherokee Indian Hospital and the Eastern Band of the Cherokee Indians. And I can't tell you what an honor it is to be a part of this conversation now that we're having a conversation now about the successful implementation of Medicaid expansion and focused on what's next. And I'm really looking forward to the conversation. Thank you.
As a family doctor practicing in rural areas, full spectrum, delivered babies, went to nursing homes, the full thing. And gradually over time, I've added more administrative responsibilities to my role because I really care about the outcomes more generally in our area, and know that investing in workforce development and investing in the design of our care in the region and how we deliver care at a practice level is really important to me. So good to be here. I'm glad to be a part of this conversation.
Hi, I'm Tara Larson, and I too would like to appreciate to our General Assembly members for all they did to make this reality. I was the previous Medicaid Deputy Director and Director for a few years and worked at the department and retired, and then became consulting with CCR, and Representative Lanier Kanzler, Secretary Lanier Kanzler, sends his hellos from our company. This is like a dream come true for me because it has been a passion, And our company has a footprint in 17 states now, and we see what North Carolina is doing and what other states are doing in order to make sure that people have health care and they get the rights that they so greatly deserve in making sure and addressing poverty and all the associated factors with that. So again, thank you to our General Assembly members, and thank you, and we look forward to this conversation.
Good morning. I'm Linda Hyder. I started my DSS work in Mitchell County and have now moved over into Swain County, specializing in all Medicaid programs. And the expansion has been epic for so many people to be able to have the health care that they really have needed for a long time.
All right, well, thank you all. So let's start by I'm going to ask a fairly broad question right now about the impact of Medicaid expansion, and I'll direct this first question to Dr. Russell. So from that sort of impact, what does expansion mean in terms of improving access to care, provider care, quality of care, and the cost of health care across our region? And if you could also talk to us about any challenges that could get in the way of those improvements.
Sure. So first, with my family doc hat on, improving access, first, we are so grateful. Having patients have better access to services is really critical. And having practiced for quite a while now, I know that people who haven't had access have had poor outcomes in their health and even death related to not accessing care. And experiencing that is not a fun experience as a provider. So some of the immediate impacts that we'll see is just some better access to care, earlier care, that reduces high cost utilization in the emergency room and in the hospital, and just better outcomes overall. As an administrator, the ability for our practices who really serve underserved communities, we're going to be more financially viable. And it has been really challenging to do that work, and so this expansion allows us to see more people and to pay our workforce more fairly and do the work that we really need to do to serve the region. In terms of improving quality and cost of care, I really, at a very basic level, you can't have quality care unless you have access to care. So this fundamentally provides that better access and the better financial viability of practices to see those patients and provide that care. And quality, for me, is how do we get more upstream, provide the preventative services, care for people with chronic illness like diabetes, and prevent the outcomes that produce negative results for them and for the ability to manage their care in a better way. So I feel like we're gonna see a lot of progress there. I think this relates to cost, as you can see. The more we're doing to prevent downstream poor outcomes, the more cost-effective our healthcare system is. So, in our part of the state, we have higher death rates for people who are between the age of 50 and 65, and a lot of that has to do with undiagnosed cancers that were delayed. Higher cost care related to that, and so I think we're going to see some improvement. You'll hear probably today about a lot of the challenges in implementing Medicaid. We are doing this after a pandemic, and we've already suffered from some of the impacts on our healthcare workforce, and so we have a lot of work to do to be able to meet the needs and the demand of that growing population that needs our care, both in the healthcare space, but also in the areas like that Linda is working in that's so important to getting people enrolled. And so I think that workforce piece is a challenge that we're going to need to overcome. And then the other piece is how do we really work to design our practices and our systems to better support the quality of care and really produce those great quality outcomes for our population.
Thank you for that, Amy. Casey, do you have anything to add in terms of, what the impact has been on your hospital and the larger community and the Qualla boundary, and maybe to dig into those workforce implications a bit more for us?
Sure, thank you. Of course, Dr. Russell did an amazing job of describing kind of the benefits and the impact, but one of the things that I personally want to just kind of raise up is the intentionality and the work between the General Assembly and the department, and the way we avoided some of those catastrophes that I thought we were going to face as we came out of the public health emergency. We had a tremendous fear that we were going to lose a lot of people off of Medicaid, and then we also feared that because of some of the delays, we'd lose people that would transition out of family planning. But because of the hard work, we were able to see a very minimal drop at all in our Medicaid enrollment, because of the really good planning and the effort that went into kind of orchestrating all that. So way to go. Thank you for that. We actually envisioned, we thought in our little small health system there for the Eastern Band, we always estimated that there were about 1,000 people who would qualify for expansion. And a big fear that we had was the cash flow problems we were going to have as those populations rotated off before expansion went into place. But it's my understanding from my team that about 500 folks that were in family planning just automatically converted to expansion without a hitch. So that was fantastic. Let me pause just a minute and point out something that's a little bit unique about our system. In our system, patients, if they lose their Medicaid coverage, they don't lose access. We still serve them, and the Eastern Band of the Cherokee Indians pays the bill. And we do that in spite of the fact that health care for American Indians and Alaska Natives is a legal and moral obligation of the United States that's really memorialized in treaties and policy over the last 200 years. In addition to that, many of you have heard me talk about this until I'm sure that you're just really sick of it, but the Indian Health Service is so horribly underfunded. It's funded at about 50% of the level of need, and it was because of that Congress actually made 2 amendments to the Social Security Act so that we could augment our health system with Medicaid and Medicare revenue. Well, that's great as long as you have patients who actually have coverage, right? So the good news was that, and I can't thank our representatives enough, and Senator Corbin, Senator Heiss, and Representatives Gillespie and Clampett for recognizing this really unique challenge that this created for the Eastern Band of the Cherokee Indians, in that we were funding the care. We were literally paying the government's bill because of this policy change that needed to happen. So fortunately, it happened, and not only did we not lose anybody, but we rotated, we transitioned about 500 from family planning directly into the expansion population, and I think it's crept up. I understand from Karen and Tara and others that we've added about 400 more, roughly 300 to 400 more patients. That's awesome. Yeah. Now, it's not without hiccups, and there are some challenges. But the department has been such a valuable strategic partner to us. I'll transition a little bit and say that those are the victories. That's the success, and the Eastern Band is no longer is decreasing its financial outlay for covering a federal responsibility, and that's great. Some of the challenges that we foresee, and I think Linda will talk a little bit more about these, is there's still some hiccups with enrollment. FFM and EPASS is going to help with that a lot, but there's still some challenges, and we've still got some challenges with the data management systems with using the FFM and officially recognizing American Indians. That's kind of in the weeds, but there are challenges. Those are not my biggest concerns. My biggest concerns are the workforce challenges that we're going to continue to experience, right? So first of all, you have to have demand. Right? We have demand because we've got a larger covered population, and then the supply will follow. And the supply, that's going to be the challenge now, is providing the access that this covered population deserves and needs. And in our system alone, we have about 100 vacancies in our system. We have approximately 20 registered nursing vacancies in our system, and we continue to have challenges with master's level therapists and behavioral health workers. The good news is, though, because of this and because of expansion, it has created opportunities for all of us. We have the ability to make our jobs more appealing in the market. And we now have the ability to partner with Western Carolina University and Tri-County and Haywood and Southwestern Community College to start building programs. Like the expansions that have happened in the School of Nursing at Western, and the new dental assistant program at Southwestern Community College, and the anticipated dental hygiene program. All of this is the effect of having a larger covered population. So there's a lot of work to be done, but it's good work, right? It's providing more care and hopefully getting us to a much healthier ecosystem out here in Western North Carolina.
That's well said, Casey. Thank you for that. And you were talking about the increased demand. So I want to pivot a little bit to ask Linda about sort of the on-the-ground work that you all are seeing at Swain County DSS in terms of Medicaid eligibility. Can you talk to us about that perspective and what you all are seeing since December 1st?
We've seen a lot of positive and negative things since December 1st. The positives were the ability to help people that weren't eligible before. The expansion helped a lot of people that were in need. The negative was staffing. The training that goes into training a medical eligibility worker to be able to determine that takes quite a bit of time to train somebody to be able to do that. The state does help some, but if there was a training center that a person could go to be an eligibility worker and get that training up front, then it wouldn't fall on the county to have to train them coming in green and really not knowing anything when you're talking about Medicaid policy and functionality coming out of NC FAST. So it was a good thing, but then it's been a struggle because of staffing and retention of quality people too.
Thank you, Linda. And I think that really speaks to one of the opportunities that we have before us in terms of training and the coordination and the collaboration that was mentioned earlier. And we also know that we've seen the demand early on. We've seen the initial data on the enrollment successes so far. But likely, from learning from other pieces, we know that over time it will be harder and harder to reach the key people who do need Medicaid and don't realize that they are eligible for expansion or face other barriers to that. And so I'm really interested, Tara, in your perspective from your former role, really, on what those key elements are to continuing to successfully enroll out expansion, especially after the initial implementation and the newness of it, and that what messaging will really be effective to convince newly eligible people to apply?
Yeah, so I think there's a lot that can be done. I mean, I think one of the things that did happen before this initial round of expansion was there were a lot of work groups with the department that brought in stakeholders to actually do brainstorming on how can we get the word out. Now that we've gotten the word out, I think there are a few things that we need to think about. We're talking about an age range that is probably very tech savvy. We're talking about a different kind of messaging. For so many years, Medicaid was a welfare program, or it was only for those who didn't have jobs, or it was for those who were only age blind and disabled, or various categories. That's not the case with expansion. It's the case that we're talking about people who are working and who have jobs, or they have part-time jobs, or they don't have benefits. And so how do we change the message that Medicaid is an insurance program? And that it is a program that can do incredible things about your health care. So I think that whole messaging and communication, that takes expertise. How do you change the marketing? How do you change it from sending out a letter that probably is not going to get to people because their addresses change so frequently, or they don't want to open a letter that's got a government address because what is that? What are they trying to do? So I think that whole idea The other thing with marketing and branding is I bet every one of you have checked your phones 900,000 times today. You know, you've also get information, you do your own banking online. You do everything from your phone, from an app. You know, I think as we start to work on expansion, we've got to make sure that e-pass, and if those of you who don't know what e-pass is, that is the state's version of automating and getting online. You can actually do a Medicaid application without ever setting foot in the DSS office. I don't know if people knew that or not. But you've also got to make sure that that application, that e-pass system, is user-friendly. Well, right now, you got to log in, you got to get an NCID, and then you have to remember your NCID, and you've got to be able to interpret what the questions are on that e-pass. And if you're not used to what those questions are, then that can cause a lot of frustration, it can cause confusion. And this, I'll give you an example. There is a question on that, on the application, that says, ask you about your medical appointments. It doesn't ask you about your behavioral health appointments, or your pharmacy, or your over-the-counter meds. But that information is used to help determine some of your cost. And so we've actually spent time literally teaching folks, going question by question by question, on this is what that question is really after. And we've done that even with care managers in the health plans, so that they, when they are talking with their individuals, can actually help them through the application process. So I think thinking about technology and how to use the application, how to upgrade e-pass so that it is user-friendly, just as easy to do as we do today. And also the marketing campaign on how do we capture. One of the things that's happening right now is the department is in the process of creating some ad campaigns going after certain maybe jobs, barbers, grocery store workers, fast food workers, retail workers, and they're looking for volunteers. So if you got anybody that you think would be a good message out there for the state and for those ad campaigns, I'm sure the department would be more than happy, and I happen to know their names, so if you need to know. But I think those are some of the main pieces to keep the word, going. I don't think this is a 3-month deal, and then we have to stop.
Absolutely, that makes really good sense. I think that's really interesting about the campaign with people from different professions. And as you said something about e-pass, I'm thinking at the work that we've done at Pisgah, enrolling people under the ACA for many years, and the technical knowledge that is needed to make that, to help someone apply through e-pass and to have it go through so that it doesn't kind of get caught up in the system is really, it's very critical, it's a big need. I'd like to sort of pivot to Linda on that from, what your experience is with kind of, not only having people go directly to DSS, but then things coming in through e-pass or the federally facilitated marketplace, that's the FFM, and what you're seeing. And I think we've heard bottleneck used a couple of times as we were talking in the planning sessions. So can you speak to that just a bit for us?
I'll be glad to. December 1st was a day that lives in infamy. It was a wave of applications that really started mid-November with people knowing that it's coming. So they started applying at that time, but by the end of the first week of December, it was all staff could see that what a wave it was. Mm-hmm. So there was a point where everybody's stepping into panic mode because, oh my goodness, how are we going to get all this processed? But it was just due diligence and keeping your head down and keep the work going to try to keep all these applications flowing the way they need to, and to give the people that were eligible for this new Medicaid access to health care that they hadn't had. Again, on the training end of it, if we could retain our staff and get new people trained and keep those people, that's where you really get the longevity of being able to process all this stuff in a timely manner. And I hope in our future we do see some kind of training ground that we can start people in instead of just bringing them into our office and starting them there.
Absolutely. Any other thoughts on that from the panelists?
Jackie, if it's okay, I was going to ask Linda to remind us about the challenges with EPASS and FFM, is it still requires a human being a lot of times at DSS.
Yes.
And Linda, if you don't mind, would you expand on that a little bit?
Sure. When they talk about EPASS and FFM, so that's all electronically. It all comes to us through a queue on a computer. They were attempting to do straight-through processing on quite a bit of the EPASS, but when the computer comes to a point where it can't find what it needs, like your residency, your citizenship, just small things like that, it'll what's it called, fall out. So it falls out, and when that happens, it actually falls to the agency to process all of that. A lot of people that apply at the FFM, theirs usually end up with us. You have to speak to people. You have to know what was your need. How, was it your whole family that needed Medicaid? Was it just one person? There's just so many questions that come unanswered when it's electronic. You know how when you call somewhere and you really would like to speak to a human being? That's kind of the way it is, you know, and when you do get to speak to someone, people's like, oh, thank goodness, somebody that can hear me. So it's, as good as the electronic part of it is, there still has to be a human being there to give people answers to questions that they is overwhelming to them, but it's something we can easily get through. And it's just a lot of training on the agency side, trying to keep people trained to be able to answer these questions that people call in and want to know, how do I have to prove my residency? I just moved here. You know, there's just simple things that we can answer, but are very complicated to a lot of people.
So the importance of that human connection, and I think also what I'm hearing you say, Linda, is this can be a really scary process for folks who haven't engaged in it previously. It can be confusing, it can be very technical, and having that additional support and the coordination of training is really key. Tara, did you have anything to add?
Yeah, I was a couple of points to what Linda was talking about was, you know, lots of times the eligibility workers, you have to look at the salaries that these folks are being paid. Many times they're not the highest paying jobs, and it takes time. Luckily, Medicaid expansion uses one of the easiest, and that's in quotes, methodologies to determine you're eligible, but it's still difficult. It still takes a lot of research to meet the federal regulations on having someone. I think there's two things that we need to think about, and that is the role of the community colleges that actually can assist with getting individuals getting a degree, associate degree or certification and becoming eligibility workers. There have been community colleges in the state that offer those classes just like they would offer a CNA class or some other sort of certification. That too takes money to keep those programs going and to keep that enrollment up. The other thing is us as community members and provider agencies and community agencies. What can we do to help prepare and train the people that we work with or come in contact on what they need to know, what that this is how you prove residency. These are the 4 or 5 documents that you could use. So going through and kind of walking the walk, if we were going to push and be of assistance to the people we serve, how can we as entities, as healthcare workers, providers, community agencies, what can we do to train our community and educate our community on what you're going to need to have in order to become eligible for Medicaid or Medicare or whatever the program is?
Thank you. And you're tying this again back into, I think, a theme and a topic that's going to come up again and again today, which is the workforce needs within the healthcare community. And, as we're focused at the moment on getting people into the system to be able to, have Medicaid and have the coverage. But going back, I'd like to direct this both to Amy and Casey to talk about how do we get more providers to accept Medicaid? What are the challenges with the services like mental health and dental that are also really needed and important? And as we have more people who are becoming eligible, we need more providers to be able to serve them. So can we dig into this a bit?
Sure. Yeah, you bring up a really important point that many practices in our region don't accept Medicaid, and particularly adult Medicaid. So the population where we're seeing expansion is the population that has the hardest time accessing care, and that gets more and more limited the farther out in the region that you get, where there's fewer providers who are accepting adult Medicaid. Our community health centers are foundational to providing that service and that support for them to grow and expand and have the workforce to do that work is so important. And they are just the foundation to that work, and we need to be growing that footprint. Our community health centers and our health systems do the vast majority, and the Indian Health Service, and so that's a critical player in this. As somebody who worked with a lot of practices in the region, as a part of an ACO, we did a lot of work to try to keep people engaged in Medicaid by helping make the relationships with payers and the contracting process easier for them, because that is hard, particularly for pediatric practices, because they haven't had to do as many payer contracts as some of the adult practices have before. And so helping that, creating that support is really essential. However, it does require practices to be engaged with somebody who does the contracting for them. So they have to have a partnership with a health system or another entity that can help them do that. So it effectively takes away some of their independence in that. And we've seen some challenges in the region in terms of how we navigate that for practices. And I would say too, I'm a big believer in value-based care and supporting. I think managed care has led us to this place where we can have this conversation about how we can control costs. There are a lot of challenges in implementation, data, how we support practices, and actually doing that work. That has been very frustrating to people who provide primary care, because they need a lot of support with it. And so anything that we need to be thinking about our system design and how we create the infrastructure to support practices in the region to better navigate their relationships with payers in this value-based care world, because it's very daunting, and they have so much work happening anyway. And when they get reports that look like their quality isn't good, but they know the data is not good, those kinds of things just make people frustrated. So yeah, we have some opportunity there, and I think what we can do as a region is figure out how we can create better systems, better technology, and invest in the infrastructure of these primary care practices to do a better job and feel more confident as we make these transitions.
Would you like to add to that, Casey?
So I certainly can't add any value to what Dr. Russell said, because she always does such an amazing job. But there's a couple things I want to mention when you talk about reimbursement. And I think that we should acknowledge also the work of the General Assembly in passing HASP, which increased Medicaid reimbursement for facilities. So way to go in that. I know that the hospitals and the health systems were really, really grateful for that. So increasing the reimbursement for these Medicaid patients obviously makes it a lot more possible for health systems to increase that proportion of their payer mix that's Medicaid. The other thing that I'll mention, or that I wanted to mention about just kind of in this theme of reimbursement, is all of the other wonderful opportunities that have happened as a result of expansion and managed care. And if you don't mind, if you'll just indulge me here just a minute, I want to share just a quick anecdote with you. About 3 weeks ago, I got a phone call from a member of my community who was concerned about a young woman who's at East Carolina University. And this young woman is first-generation college student with no intergenerational wealth, but she has chronic disease issues that require, of course, a lot of medication management and medication therapy. And this family member called me and was concerned that this young student did not have access to their medicine. And because expansion also made it possible for the tribe to build a managed care entity. You know, for those of you that don't know this, the Eastern Band was the very first Indian managed care entity in the United States. And it was a really, really big deal.
Wow.
Thank you. So, and I'm not exaggerating when I tell you, I call Gwen and I say, Gwen, there's this girl at ECU. And I know her first and last name, and that's all I know about her, but I'm pretty sure she's one of ours. And so in about 30 minutes, Gwen is able to go in the system, find out that she is, in fact, a Medicaid patient. She's one of our patients. And Gwen calls the local pharmacy down in Greenville and gets this girl her medicine. And so this girl, by providing that relief to her, right, she will stay in school. She'll get her education, and that will be an example of creating generational opportunities, right? Generational opportunities, just like Dogwood is focused on. So there's so many wonderful things about this. And the other thing that I want to mention, and Jackie, I'm sorry if I get out of sync here, but another tremendous opportunity, right, is, and I'm sure Dr. Russell will agree, that one of the most frustrating things about taking care of patients is taking care of a patient that needs a resource you know they can't get, right? When you're looking at a case and you know what this patient needs, they're never going to get it. Either it could be a really expensive medication, it could be a visit to a specialist, or it could be safe housing and transportation and food, right? And so because of Healthy Opportunities and Impact Health, now these primary care providers, these medical homes, they have so many more resources now. They've got access to enhanced care management, and then those care managers can actually dig in and reach out to people like Lori Stradley and others to try to get folks the very resources that they need to really be healthy, right? It's just an amazing opportunity that's happening here in North Carolina. And I really, let me just finish with this. I'm confident that before those of us in this room take up the rocking chair, we are going to see improvements in population health as a result of this. And it's really exciting.
I just have to say that again. It is really exciting, what you've just mentioned. And, you know, what Casey has just said, all of that connection, the connection of being able to call somebody to, you know, provide that support, the connecting to places like Impact Health and the Healthy Opportunities Pilot. And we're going to hear a lot more about that this afternoon, but it does impact what we're able to do in terms of population health with the impact of expanding Medicaid. And, you know, I see some nodding heads, so I want to open it up for any other thoughts just about that connection to Healthy Opportunities from the panel.
Yeah, I think, first of all, I'm thinking that, Casey, I better stay out of my rocking chair a little bit longer, right? But seriously, the Healthy Opportunities, when you get on the Medicaid expansion, it doesn't matter what kind of Medicaid you're on, for the most part, you're eligible for Healthy Opportunities. And so I think that piece of being able to, it gets back to training though. Providers have to understand what Healthy Opportunities is and what those 20-some new services can be and how that's going to be billed and what that can mean. But to be able to do that today is just amazing. We knew you can treat the cardiac problem, but if the person doesn't have a safe place to stay at night, or the person is living under the bridge, do you think they're going to take their medicine even if they get it free? No. They've got to take care of their basic needs. So the healthy opportunities is just amazing for any kind of expansion or any kind of health care, period, regardless of the payer. So.
Absolutely. I mean, we are talking about the social determinants of health, all of the things that happen inside of the walls of that doctor's office or provider's office, as well as everything that happens when that person leaves that room. And sometimes, you know, when we talk about the work we do at Pisgah, the connection to health is, well, how are lawyers fitting into that? But we're really practicing poverty law in areas of housing and safety and helping people with those other issues that can help them stay healthy.
It's all about where we live, learn, work, play, and pray. So,
absolutely. Yeah. All right. Well, I want to, we're going to have some time for questions from the audience, but first let me go ahead and just ask a final question to each of our panelists. We can maybe just go down the line. I would love to just ask about final thoughts on, you know, as you've had this rich discussion, as we've been talking so much about all of the challenges and the successes, and of course, really focusing on all of the opportunities that lie ahead. You know, what do we want this group here to be thinking about as to what comes next in terms of healthcare access and policy and the continued success of Medicaid expansion? So I will start with you, Casey.
So at the risk of being kind of annoyingly redundant, you know, the thing that comes to mind is just this, we need this continued vigilant focus on workforce development. And I think that we can all get excited about workforce development, right? I mean, it's opportunities for our university system, it's opportunities for our community colleges, it's opportunities for so many partners to then help lift people up out of poverty by giving them a path to economic mobility, right? And along this path of economic mobility, especially out here in the rural counties of Western North Carolina, they actually get an opportunity to participate in meaningful, worthwhile work, right? And so not only can we create these opportunities for people to stop this intergenerational poverty, right, and the intergenerational stress and trauma of being at the lowest economic strata, right? Get folks out of poverty and then give them an opportunity to be significant in the lives of somebody else. We can't go wrong with workforce development.
Thank you.
We've mentioned a lot of challenges, but I can't say how optimistic and excited I am about the opportunities we have specific. I'm so proud to be a citizen in Western North Carolina. The level of partnership in this region among practices, among our community-based partners and now legislators is just, to me, transformational. And having been able to see the first stages of healthy opportunities roll out, where you have a child who's been in and out of the emergency room and you can get their roof fixed and fix the mold in their house that's causing them to have these exacerbations, that to me has, you know, really changed the way I think about my career and my hopefulness as a primary care provider. And I think, you know, from this group, we should take forward all the investments that we need to make this as successful as possible. We are leading the nation in this work, and that is incredibly exciting.
Totally. So I agree with everything folks have said. I want to bring us back to the topic on the eligibility. Medicaid's going to require all these eligibilities to be redetermined in 12 months. And what we don't want to have happen are folks falling off the rolls. When I was at the department, I actually planned for a churn. There's actually a term. You actually budget a churn rate for people to fall on and off the rolls, which is horrible to say. But it's a reality. So I think we need to continue to have due diligence in making sure that people understand that it's important to keep up with your receipts, to actually pay attention to whatever communication type that you're getting. And practices and folks can see that. If you go onto the system, you can actually see when a person's eligibility is going to be up. And so trying to make sure that's going to stay in the forefront is really important.
Thank you.
I guess I'd like to focus more on the staffing at the county level, because without those folks to be able to help people navigate through their applications, or what Medicaid product fits them the best, or what will help them the most, and getting people trained in those positions to be able to be that navigator that anybody would need. Somebody's parent, somebody's uncle that really has nobody no more. They look to that worker to help them navigate to get the Medicaid product they need for their health, for their future. So a group that could train well and get people in these community colleges, like you said, with the CNA, would be awesome for any county to be able to get somebody that already had education and that could step into a job and work it instead of having to spend 6 months or more to train somebody to be able to do it. And when you get that phone call from somebody that's really in need, and you've got people on the phone crying because they really don't know what to do, and so they're asking that eligibility worker, and she's really not a data entry clerk or an eligibility worker. She's really a navigator. She really helps people get to what they really need to be safe in their home, or health-wise or dental-wise. So there's a lot of important people at these agencies that need to be compensated for the very important things that they do.
Well said, and bringing it back really to the people who we are working face-to-face with, who need this coverage, and the support of the folks who are on the ground, on the front lines, providing that much-needed support and assistance. So, I've heard from the panelists as you're talking, these, we're optimistic, continuing these investments, workforce development, and the connections. And in our opening remarks from all of the speakers, I heard so many of those themes as well: connections, collaboration, the opportunity, and the responsibility that is really before us. And so I think we have certainly discussed many of the important issues on the impact of Medicaid expansion right now in our region as we know it, and what we need to think ahead on. We would love to open it up now to the audience, to you all, for questions and comments and discussions so that we can engage and hear from you, and certainly hear from our panelists on those issues or questions that are really highest in your minds. So I believe we have someone running with a microphone. Thank you, Emma. So yes, let's go ahead and let's start the question. And
we're going to open if any of the legislative guests want to ask questions. We'll open with you, and then I see a couple of hands. And I'll make sure all right, no pressure.
yeah, I see a lot of hands. Thank you.
All right, this is going to be harder than I thought.
I think this question is maybe for Dr. Russell, related to practice management for independent type practices. So if a practice how much overhead would you add if you want to take on, I guess maybe my question gets to, it seems like a lot of the cost in healthcare today is the staff you have to have just related to billing. So I don't know if the industry as a whole,
Yes.
industry as a whole has quantified that. Is 30% of your overhead related to the billing employees, and then if you're a non-Medicaid practice, then you're going to add Medicaid.
Yeah.
And how much overhead does that add to you?
I think you're in the ballpark, and the more payers you contract with, the more work it is around the contracting, the more work it is around the individual contract terms. So especially as we go into value-based contracts and there's quality payments, potential risk, and having that ability to create the infrastructure that's individualized for all of these payers is really, really expensive. And We have denials for payment because we don't have the system in place perfectly for every payer. We are measured on quality performance with things that require capturing data that isn't easily captured in the EHR, so we hire people to manually go into payer portals and put the data in. That to me seems crazy in today's age when we have so much technology and we don't have it implemented in healthcare the way we need it. So absolutely, that is something that I think if we could provide a better technical infrastructure for reporting and quality and data for our practices, that they didn't have to pay or at least had subsidies to support that, I think they would, that support is very needed and would help them be much more successful. MAHEC provides practice support, and that's paid for by the state, which is really helpful. We do a lot of work with practices, but small practices have a hard time ensuring that they have the people who have the training and the skills and the abilities to manage the complexities of all these payer relationships. And so that's where it becomes challenging, and I think some people just give up and say, I'm not going to be able to do that, I'm only going to do this part of business. And unfortunately, that limits access to care.
Great question, thank you.
Good morning, everybody. It's good to see you all. My name is Honey Estrada. I'm the president of the North Carolina Community Health Worker Association. And I was jotting down some notes during this incredible panel. And, Linda, I heard you talk about the need for training. And Jacqueline, I heard you touch on the need for human connection, not just inside of the clinic walls, but outside of the clinic walls. And Tara, I heard you talking about the need to educate our community members. And Dr. Russell and Casey, I hear you talking about workforce challenges and healthy outcomes. And I can't help but think about the fact that we have an incredible workforce already here, not just in Western North Carolina, but across the state. Community health workers.
Right, right.
Yes.
Yeah.
At the North Carolina Community Health Workers Association, we've been working really diligently with our workforce across the state as advocates to really think about how we can attack what we're really faced with, our challenges, and the fact that these community leaders really are the trusted messengers inside of our communities, our rural communities, our vulnerable communities. But we don't yet have a comprehensive statewide strategy. And as we consider essentially integration, I would love to hear from the panel your thoughts on what this dream could look like, not just for our healthcare system, but a world where we've got CHW integration readily woven into the thread of public health and healthcare.
So I'm ready to come over the panel here. Here we go. So CHWs and peer specialists are just amazing, amazing pieces of this system. The value that they bring to the table in all aspects of a person's life, but they're not reimbursed. They're not reimbursed. If they have to be part, in order to get paid right now in the system, you have to be part of another Medicaid service. It's not a standalone reimbursable service. Understand why part of the world that made that like that at one point in time. But our system has evolved. Now with managed care and all the other things that have happened in the Medicaid program in North Carolina for the last 10 years, CHWs, peer specialists, youth peer specialists, family peers can make a big difference so that they allow Dr. Russell and her team to do what they do best, provide the care, that Linda and her team can be that in-world of checking the box and making sure all the federal regs. But I think the more that we can learn to value and put as much importance on that local voice, that CHW, that peer, I think we have to get them at the same level of appreciation that we have Dr. Dr. Russell and Casey and myself and everybody else, because without them, our system is going to continue to be fragmented.
Well, and let me just add, I can't say that any better than you've just said it, but how also critical it is as we talk about how we're going to reach the folks who haven't enrolled. The trust and the support and being a part of the community for community health workers will be an essential piece of how we do reach those folks.
I want to piggyback on something Senator Warren said on administrative burden. I'm Hyder Reagan-Warren, I'm a grants officer with Dogwood Health Trust, and in my grants meetings with folks this year, I asked the question, what are your challenges? And one challenge that's come up from everywhere from Eastern Carolina University's safety net oral health clinics and Sylvan Spruce Pine, it's come up with Dr. Hudspeth's clinics, with Blue Ridge Health and others. It's actually related to credentialing. And how in our state it can take 6 months or longer to get a provider credential, or when you're trying to work on your pipeline for mental health and your LCSWA, which is the therapist, right? They now have the full LCSW, but you have to credential them again.
Right.
And that could take many, many months.
Right.
One of the biggest barriers I heard again and again was credentialing, and how one person's like their fantasy is, can we make what happened in Virginia happen here? Where through an FACHE delegated credentialing is like 48 hours in a credential. I know in Kentucky it's 2 months. So we just wanted to lift that to Casey or to Amy. What's your experience on the credentialing side? How long does it take to be accepted by Medicaid or MAHEC?
That's a great question, and it is a very important point because, again, this is something that is handled differently depending on the payer. And each practice has to have an internal process to manage that, which is challenging. And so you could potentially start somebody in your practice seeing patients, and they can't see every patient, which is another administrative burden. And if you're not, it's about being credentialed and enrolled, and then also being enrolled in the variety of the right plans. So oftentimes we don't understand that there's several different, payer plans under United or under Blue Cross Blue Shield. And if they're not correctly enrolled in every single aspect of those plans, we could potentially not get paid. And then that also relates, to that enrollment to how we assign patients. And that assignment relates to our quality payments and our ability to participate in value-based care. So there's a ton of downstream impacts related to this upstream thing of hiring a provider and getting them on board and trying to help them see patients. So absolutely, thank you for raising that issue.
Yeah, I don't really have a lot to add to this because in our system, and I'm satisfied this is a concern. In my system, the patients still get the care. We just don't get reimbursed for it. The tribe ends up paying the bill, and unfortunately it does happen. So I appreciate you raising it up.
Hello there. Sue Lynn Ledford, and I see some of my friends sitting in the room. It's really good to see some of the familiar faces in the room. But as you guys were talking up there on the panel, and over the past few months, I just see opportunity in so many of the comments and the opportunities that you brought up, and I think ones that we have. And one of the priority opportunities, I would say, is harnessing what sometimes I call a public-private and governmental partnership that looks at it in a systemic way. Because what happens too often is we're so siloed, we're not doing that. And Linda, you hit it on the nail head. The lack of being able to maintain that front line and those service organizations. I moved back here for the purpose of trying to make a difference in the math that you have in your executive summary. It is, I sat in Wake County for a long time, and we were all blue. We looked really good there, but I knew all of my family and all of my friends and all of previously were not. And I'm wearing red today. I didn't know that you were going to have this red map, but I guess the question I have is, how do we explain, not at governmental speed, but at private market speed, something together quickly to address this frontline training opportunities? Because we've really been building this jet as it's flying, and I'm now leading one of the health service organizations, probably the furthest one west in Cherokee County. And that's what it has felt like from a healthy opportunities perspective, Medicaid enrollment perspective, everything that we're trying to do to assist the people in Cherokee, Clay, Graham, and Swain counties. It's overwhelming. And I believe some organization, and I think our PHPs, our provider health plans, NCOs, could help fund some of this, because guess what? They get the customer. And I think that, some alignment with those different organizations, such as PHPs, DHHS, and, what we currently have in our communities, there's really a right opportunity there. And these trainings need to have consistency, because Linda, I would say it takes a good 6 months to get someone up to speed. But if everyone came in with some consistent understanding, you could launch so much faster. And our community health worker friend over here at the other table, I agree. The people are there. Even some of our Medicaid enrollees could be doing what we're asking to be done. So,
All right. Yes. Thank you.
So I think would totally agree, Sue Ann, on your comments. I think one of the first steps are rooms like this, where people are getting together and talking about that. Talking about how the department, how the General Assembly, and how us as can make those difference. A couple examples I'd like to throw out where there were several health plans, the department, and several community agencies where we literally got in a room and we planned a training that was going to be for the community. And it was like, no, department, we don't want you just to come and read your PowerPoints. This has got to be, open up the computer, get on the screen, and let's walk us through question 1, question 2. Or, hey, existing Medicaid recipients, read this. Tell us what works and what doesn't. What's making sense? So I think being able to, all of us, put some skin in the game, to be able to actually say, we at CCR, we fought for Medicaid expansion a lot, but what are we doing to actually get the word out? We actually spend time at a homeless shelter or the library and actually spend hours just manning tables so that we can actually teach people how to do an application or how to be prepared. So I think being in the room as a community and getting your partners, and actually it's a collaboration, right? And we all need to put some skin in the game. It shouldn't all be paid by the department. It shouldn't be all paid by the General Assembly. You're right. Health plans have some money. Let's all put some money into the system and try to get the training. If our values are aligned and our goals are the same. Someone told me years ago that true collaboration is money on the table and hands behind the back. It's about trying to get the system moving. So thank you.
As I've been able to participate in a lot of the health policy initiative meetings, and we've had various different organizations come and present on their role in the community, and I think the connections made in that forum with our community colleges, our education institutions in the region, with our community partners, has been really essential to problem solving around the workforce pipeline, because there's so many creative ways that we can engage people in supporting the health of our community. And when somebody has an experience where they make a difference in somebody's lives, that can really inspire them to pursue more in a career. Our chair of our Department of Psychiatry, he's been at MAHEC for 17 years, and he's retiring this year. He told me that one of the applicants for the program, I haven't heard from the match whether they're in the program or not, but was a frontline worker at CeLo when he first started doing telehealth, and they got really inspired by seeing how he was engaging patients at that health center, and they decided to pursue a career and mental health. So, all of these experiences and engagement for people, regardless of where they enter the health system, can really, really create a pathway for them to contribute in a really meaningful way.
All right, I think we have time for one final question. Thank you.
So I'm very grateful for, my name is and I'm part of Healthcare for All residents in North Carolina. And I'm really grateful for this meeting and for addressing Medicaid expansion. This has just been a wonderful opportunity for me to participate and hear what's happening. And my question is, a lot of the issues that you're addressing now with Medicaid expansion could be solved with Medicare and Medicare for all. So I would just wonder, maybe I'm premature in bringing this up here for now, but I'm wondering what your thoughts are about that at this time. Thank you.
So you probably don't want me to answer that question because I just went on Medicare. Let me just be upfront. So I'm still trying to figure out that system. But seriously, there are huge differences even with Medicare and Medicaid. Medicaid is a state-operated program. So Medicaid changes from state to state. There are some things that are across the board. But most services are optional. Most eligibility categories are optional, unlike Medicare. Over the years, Medicaid and Medicare, and I know have tried to align their policies. Most recently, with the managed care regulations, they tried to align the systems. There's still a long way to go. Medicare is 100% federal, and so that's congressional action, and we know how Medicare, how that's come up over the years. But I think to Dr. Russell's point, the more that we can align not only Medicare, but commercial payers, whether it's the credentialing process, the billing process, the better it's going to be for the member, so that you're not having to say, oh, I just came off the state health plan, and now I got to think about what Medicare is going to be, and how do I access? But it also makes their payments system easier, their credentialing system, which gives them less time to deal with the administration and more time with dealing with the people who are walking in the door, which is what it should be all about. So the more I am totally 100% in support of trying to align the payers in their values as well as their reimbursements, as long as it's not going to be the lowest denominator and we're working on the highest denominator. So
I will make a comment. In health system science, we say a system is perfectly designed to produce the results it produces.
That's right.
So we got here somehow. So there's always an opportunity for us to step back and say, how did we get here, and what can we do from a bigger picture to move forward. I never knew when I started practicing medicine how much health policy really impacted the day-to-day work that I do. I really understand that now. So you are really critical to this conversation. and how we make a system that ensures the security of essential needs for our community, particularly primary care, particularly human services, that will help our communities be healthier. And I don't have the answer to that. I think that's part of this conversation, is we really need to be exploring that together.
Thank you. So you're right, Amy. That is part of this conversation. Excuse me. That is part of today's conversation, and what a wonderful conversation we've had. Thank you so much to the audience for your engagement and good questions. Thank you so much to this great group of panelists for digging in and really talking about the impact of Medicaid expansion. And I also think really pulling together the other two topics that we are going to be talking about throughout the rest of today. It has been a pleasure to moderate this panel. Thank you so much, and thank you to the panelists.